Okay, this is part of the continuous medical education, and we're going to discuss a little bit on heart failure today with reduced ejection fraction. And أنا خدت موافقة من السبيكرز. I thank you so much. دكتور عمرو كمال، دكتور حاتم حسن, thank you so much. We're going to reduce the time. وأنا بالنسبة لي هتكلم في خلال 5 دقايق. طبعا دكتور أشرف مبسوط وقال لك إيه هنخلص على الوقت. My question is, are all heart failure patients with reduced ejection fraction, are they all the same? احنا عارفين في 4 pillars of management. كانوا في European guidelines, كانوا في American guidelines, but how to start, when to start, how to start. So for the sake of time, I'm going to skip a lot. وأوعدكم إن أنا أديها لكم مرة تانية بالفول data بتاع كل المedications دي, and we'll skip to one of the most important really presentations given by the European Heart Failure Association. منهم كلهم صحابنا يا دكتور سيد فرج. They divided the patients into different phenotypes. يعني إيه phenotypes? Patients are not all the same. We have patients who have CKD and patients who are not. Patients who have atrial fibrillation, patients who are not. Patients with elevated blood pressure, patients who are not, and patients who have a high heart rate or not. So according to this, في وجود أو عدم وجود الcongestion, this is the way we manage patients and we treat. So what if we have a patient with a blood pressure is high, heart rate is high, no CKD, no AF, we can use any of the 4 pillars at the start. You can use any, this is not really important, but definitely في data بتقول إن البيتا blockers when the heart rate is very high improves symptoms a lot. SGLT2s can always be given regardless. What if the patient has a low heart rate? And this is not quite common in heart failure with reduced ejection fraction, but we can use the RAS blockade, we can use the SGLT2s, we can use the MRAs, of course no beta blockers, no ivabradine. What if the patient has a low heart rate and low blood pressure? The only data that we have for lowering mortality and lowering outcomes are with the SGLT2s and the MRAs. Actually, MRAs in heart failure, I know they are used as antihypertensive, have a very, very modest effect on the blood pressure. What if the patient has a high heart rate and a low blood pressure? The data given by Professor Wael Kilani. Ivabradine if the patient is sinus, digoxin if the patient is having atrial fibrillation. And of course, the SGLT2s, the MRAs can always be given like the previous patient. Okay, so this is important. What if the patient has a high heart rate and the systolic blood pressure? Always go up with the ones that reduce hospitalization and reduce mortality. The highest rate of mortality reduction is seen with the beta blockers, and the highest rate of hospitalization reduction is with the SGLT2s. So actually we get a lot of patients with a little difference in them. What if the patient has CKD? We can give SGLT2s not only in heart failure, but we can give them as treatment of CKD. ACE inhibitors, and RAS blockade in the form of sacubitril valsartan are beneficial for the kidney. So if you want to sequence your medications according to your patient, look at the hemodynamics, look at the confounding factors or the comorbidities, and this in 3.5 minutes is the only way I can give you the message because of the time. So we have 4 medications to take home that reduce cardiovascular outcomes, especially mortality and heart failure hospitalization. The guidelines don't say how to start, what to start with, whether the American, whether the European. But if you look at the position paper given by European Society of Heart Failure, maybe sequencing them according to the blood pressure, heart rate, other comorbidities like AF, CKD will help us there. Thank you so much, and for the sake of time, I try to make it as short as possible.
طب أنا عندي سؤال اللي بياخد حوالي 4 ساعات. لا خلاص.
معاك
Okay,
هنسهر الليلة.
we'll move for the next.
Thank you.